So I know many of you all have been with us for really the entire day. So it's been a full day, but hoping that it has been fulfilling and galvanizing for all of you. I wanted to share that we were also expecting to welcome Congresswoman Lauren Underwood, who represents the 14th District of Illinois, but her appropriations committee obligations have run a bit long, so she's unable to be here with us today. But with that being said, it's really my honor and privilege to introduce a remarkable leader and advocate for our community, Congresswoman Dr. Alma S. Adams. As a person who identifies as a Black woman and someone deeply invested in the health and well-being of our community, it's truly inspiring to see her unwavering commitment in advancing Black maternal health. Dr. Adams has been representing the 12th Congressional District of North Carolina since 2014, and her dedication to public service spans decades. Congresswoman Adams was sworn in as the 100th woman elected to the 113th Congress. She currently serves on the Committee on Education and Workforce and the House Committee on Agriculture, where she continues to champion policies that benefit minority-serving institutions and historically Black colleges and universities. Notably, she secured $85 million annually for HBCUs through the Future Act and established a $50 million R&D grant program in the 2023 federal budget. A co-founder and co-chair of the Black Maternal Health Caucus, Congresswoman Adams has introduced the groundbreaking Momnibus package, addressing the unacceptable rates of mortality and morbidity among Black parents. Her leadership extends beyond health equity, as she also co-chairs the Congressional Bipartisan HBCU Caucus, fostering partnerships and securing vital resources for HBCUs. Dr. Adams's career in education and public service is a testament to her lifelong commitment to social justice and community empowerment. From her tenure as an art professor at Bennett College to her leadership at the North Carolina General Assembly, where she championed affordable health care and minimum wage increases, she has always fought for a better future for us all. Please join me in welcoming the amazing Congresswoman Dr. Alma S. Adams.
Wow. How you doing?
Very good.
Well, you are amazing. Thank you, young lady. Good afternoon, everyone. Thank you for waiting on me. We just got finished votes, and I'm just delighted to be here. I thought I was going to miss it, but I'm glad to be here. And that was a great introduction. I need to carry you around with me. I do represent the 12th Congressional District in North Carolina, Charlotte, Mecklenburg. And I'm happy to be here. I bring you greetings on behalf of our Speaker of the House, as well as our leader, Hakeem Jeffries, the Black Maternal Health Caucus, the Bipartisan HBCU Caucus, and all of my colleagues in the U.S. House. Thank you for allowing me to share the screening with you today. It's a very important film, and I hope that its impact reaches far and wide beyond this room, and that it becomes a strong call for the change that must take place within our healthcare system. Now, while I'm sometimes addressed as Dr. Adams, that title is academic. It's not medical in nature. But you don't need to be a member of the medical community to recognize that there is an injustice in the medical system. And so I do applaud the National Academy of Medicine and its Culture of Health program for working to shed the light on our country's deep systemic issues that contribute to the racial disparities and that we see in our healthcare system today. Health is one of the H's that I work on: housing, healthcare, higher education, and hunger. Those are issues that are important to the constituents that I represent and all of the constituents across this country. But I do want to thank the film director, Dr. Myseer Keels. Thank you so much for your work for elevating this issue. These are not new ideas. And today, even a quarter of the way through the 21st century, in the wealthiest nation in the history of the world, disparities in healthcare continue to grow. But the reality is that your race often impacts not only access to care, but the quality of care that individuals receive. Equity in healthcare really is an American issue, but oftentimes the work of raising awareness and leading the charge falls on those from communities of color who care enough to persist. In Congress, I am working through the Black Maternal Health Caucus to address the disparities in maternal health, because the Black maternal health crisis is perhaps one of the most glaring examples of this inequity, given that the United States is only one of 13 countries in the world where the rate of maternal mortality is worse than it was 25 years ago. Just think about that. 25 years ago, things were better. And so our maternal mortality rate is the worst by far in the developed world. But most disheartening is that 80% of those deaths are preventable. 80% are preventable. Just a few years ago, it was 60%. So it's increasing, and the problem is growing, and it's getting worse. So this is unacceptable. It's unacceptable to me. It's unacceptable to all of you. But as bad as these statistics may be, this crisis is not affecting all Americans the same, because Black women are nearly 3 times more likely to die of pregnancy related complications than white women, regardless of economic status. It doesn't matter how much money you have, how great your insurance is. That inequity still is there. But our communities already have the solutions. And we have deep knowledge on what needs to be done to address these issues, and by doing right by our mamas. And so our caucus is working to direct the federal government to allocate the funds needed to uplift and expand this critical work. I'm just delighted to work with my sister, Congresswoman Lauren Underwood from Chicago. She was the youngest African-American woman to enter Congress a few years ago. And it's just been my pleasure, even though there is a gap in terms of our ages, we still have the same commitment on this cause. And so in a rare show of bipartisanship, this Congress, the Stillbirth Prevention Act, which I co-led, was recently passed by the House and the Senate. And it should be passed into law any day now. Any day now. It's on the president's desk to fund the programs that will educate families about preventing stillbirths. Stillbirth is a part of our nation's maternal and infant mortality crisis, but it's been a silent crisis that's not been talked about enough. And so Black women are almost twice as likely to experience stillbirth. I don't know why it is, but everything that's problematic is connected with us as Black women. And we need to do something about that. It should not be. But this new law will help change that tide. For our veterans, the House Veterans Affairs Committee held a hearing in March of the Maternal Health for Veterans Act, and one of the 13 bills, if you heard about the Momnibus. I love that name, the Momnibus, because it's all about the mommies. And so it would build on the success of the predecessor, the Protecting Moms Who Served Act, that was passed into law in 2021. And so it requires that veterans get access to the community maternity health providers that they need. We need to make sure that we provide for our veterans who provided for us, who put their lives on the line, and we need to make sure that their lives continue to matter to us. So it also continues funding for a nationwide study of an unprecedented size on the racial and ethnic disparities in veteran maternal health outcomes. As of April, Congress passed and President Biden signed into law over $100 million for the Black Maternal Health Caucus priorities in fiscal year 2024 appropriations in that funding package. Let's give it up for that. That was so significant. Now it's going to support our community-based organizations who are working to improve maternal and infant health. And these are the people who are on the ground, working through various organizations to make a difference. And that's where we need to provide the funding. And so while it's not going to solve everything, there's no denying that this is an extraordinary start. The maternal health inequities in our healthcare system have stolen countless mothers from their children and their families. And so the 13 bills of the Momnibus Act would fund programs and initiatives that would reverse that trend. So it is a privilege, and let me just say that, to work alongside each of you to realize this vision of quality health care and thriving futures for our Black mothers and their children. I do appreciate all that you do. I appreciate the work that you will continue to do because we cannot stop, and our mamas and our babies certainly deserve our best. And I just want to remind you to continue to plant those trees in the community because they will be there. They'll provide the shade for the future. Because somebody once said that a community can only grow great when old men and old women plant trees under which we know we will never sit. Thank you all so very much for having me. God bless you.
Black people are grieving all the damn time. We're grieving every moment.
The CDC declaring racism a public health threat.
COVID has been the most blatant example for all the world to see. In every community, disproportionate access to goods and resources can quickly turn into poor health and death. But that happens every day, slowly and quietly, for chronic diseases.
There was always just this feeling, don't make waves, put your head down, get the work done, but don't ruffle any feathers. And then George Floyd happened, and I had a really hard time figuring out how to deal with my emotions, and I can't be silent anymore.
Imagine a fully loaded jumbo jet with 220 passengers and crew taking off and crashing today. And the same thing happened every day next week. That's exactly what is occurring when we say there are racial disparities in health in the United States. Over 200 Black people dying prematurely every single day.
The pulse of Black America is that we're grieving. This system, this society weathers us before we even come out of the womb.
Black communities, we've seen consistently a higher rate, sadly, of infant mortality. And we've seen that, and we have documentation of this at HHS, among college-educated women who are professionals and have prenatal care.
Around 5 months, I went to see my doctor for a routine prenatal visit. As I was sitting in the doctor's office, I noticed a picture on the wall that said, if you feel like something is wrong, something is wrong. Tell your doctor. I told my doctor. I told her that I was having severe pains, and she said, oh, no, you're fine. Go home, and I'll see you next time. 1 week later, I went into preterm labor. My son was born, 1 pound, 3 ounces. He could fit within the palm of my hand. We were told he had a 0% chance of life. The chief of neonatal surgery decided to try to resuscitate him. It worked. The doctor who delivered my son apologized. She said, you were right, and I didn't listen to you. Give me another chance. 2 months later, I was pregnant again, so I went back to her. At 16 weeks, I went for an ultrasound at the clinic and saw a different doctor who was working that day. I found out again I was in preterm labor. The doctor told me that the baby was going to abort. I said, no, you have to do something. But he was adamant, and he said, just go home. Let it abort. You can get pregnant again because that's what you people do. My sister picked up the chair and she threw it down the hallway. Nurses came running from everywhere to see what was wrong. A nurse called my doctor, and she placed a cerclage on my uterus, and I was able to carry my baby. This is what desperation looks like, that chair flying down a hallway.
It has taken me a very long time to be able to tell the story without being reduced to a puddle of tears.
Serena Williams, Beyonce have had to advocate for themselves so that they can survive
I had to make sure that I entered into that space with survival on my mind.
There is a structure within the United States that protects the health of white Americans, but doesn't protect the health of Black Americans. It actually damages the health of Black Americans. This structure is racism.
The historical record shows that there has never been a single time or place in American history when the Black mortality rate was equal to the white mortality rate. In the first decades after emancipation, white fears that the freed Negro population would continue to grow and possibly outnumber white Americans were calmed by the high Black mortality rate. In 1928, Professor S.J. Holmes wrote in the prestigious journal published by the American Association for the Advancement of Science that between 1860 and 1880, the Negroes increased from 4.5 to 6.5 million, and by 1900, they numbered almost 9 million. Panic over being swamped by the rising tide of Black humanity subsided when the 1910 and 1920 census showed that emancipation caused an increase in the Negro mortality rate. Demographers began to conclude that as long as the Negro death rate remained high, the race problem will ultimately take care of itself. In 2019, the year before the pandemic, the year before George Floyd's murder, 884 of every 100,000 Black Americans died, while a much lower 740 of every 100,000 white Americans died. In 2020, the first year of the pandemic, the year George Floyd was murdered, 1,119 of every 100,000 Black Americans died, while only 835 of every 100,000 white Americans died. After the pandemic began to subside, after the Black Lives Matter uprisings calmed, we Black people continue to die at much higher rates. In 2021, 1,110 of every 100,000 Black Amerians died, compared to 863 for white Americans. While these differences may seem small, if Black Americans had the same mortality rate as white Americans, during just these 3 years, more than 280,000 more Black people would still be alive to make Black America healthy and strong.
You can say that we don't have genetic evidence for race, but race exists. Race is originally conceived based on observable traits, the way we look, skin color, hair color, eye color. And now that we're in the post-genomic era, we have more insights into whether or not these discrete categories coming from social, political, and cultural ways of grouping people, they really reflect the genetic makeup of humans as a species.
Race is the social construct that represents processes of racialization. It represents policies that have established what it means to be white in this country and the privileges or unearned advantages that come along with being white. It doesn't look like that today, right? We don't have slavery as this legal institution in this country. It changes and evolves. It means that our measures and our conceptualization of racism has to evolve with it.
When we look at mistreatment, when we look at the ways on which the hospitals contribute to not listening to patients, not believing them, not appropriately managing pain, not all the things that you hear about the poor treatment of Black people in their healthcare seeking, I feel like it's super important for us to be making sure that we are not continuing to perpetuate that problem. I was on a trip to Washington, D.C., and I started to have this incredible vaginal itching. I didn't know much about that tissue down there. So I went to see the nurse, who was assigned to the group. And I said to her, I have got this itching going on down there. And she said to me, I can get you to the sexually transmitted infection clinic.
She went right there.
She went right there. And I was not sexually active at the time. And I said, I'm pretty sure that that's not what's going on. You got any other ideas? And she didn't. So, I put up with it. And I don't know if you've ever had a standard yeast infection, but I went to see a GYN, white male, and the exam hurt. It was very, very painful. So it was hard to stay still. And he said to me, you're a very difficult patient. With that, we finished the exam and, I was treated, but that was my first experience seeking gynecological care.
It's not the Black body. It's the dehumanization that has occurred in history. It's easier to think of the Black body as being inferior. Of course, they're going to have more diseases. That's how slavery was allowed to exist for so long.
Thanks to genetic sequencing, what we find is that humans have moved around and mixed with each other. This has happened time and again in the history of our species. You can't really draw a box around a bunch of people and say, oh, their genes look alike. That just doesn't happen with genetic data. It just all flows from one continent into other. But this, of course, requires that we have genetic data from different regions. And this was one of the shortcomings of some of the early genomics data set consortia. When your sampling setup is such that you select people living at the extremes of that diversity, what that often doesn't take into account is that there are all these other people living, and if you sequence them and plot them, they will cover those extremes, and you will no longer have these distinct and discrete sort of, oh, Asians are here, and Africans are here, Native Americans are here.
Race being a social construct, which it is, but it's a construct that is with us every day.
If you don't see my race, then you don't see all of me and what I go through. You're not thinking about how I interact with people on a daily basis, the biases that I face. You are ignoring a very important part of who I am.
When you have these experiences, as a young woman, and you're thinking, okay, again, doing the analysis, what am I going to do here? What am I going to see that won't hurt me? And then the history of Black women and GYN is so dark. It is so brutal. But I was motivated around that time to decide, you know what? I think I can do a better GYN exam. I think I can be more respectful with women during a GYN exam. And so it was a motivation to go on to become a midwife. I can attest to the fact that I do a practically painless GYN examination. It doesn't matter where we look, in our lives, professionally, or from a GYN perspective, or from childbearing perspective, it's there. The embodiment of racism.
Mm-hmm. Slavery, that was the first thing that happened. Then slavery moved us on to the Jim Crow South. In the Jim Crow South, we were segregated. We were discriminated against. We didn't have those opportunities. So at the point when you don't get the education that you need, you can't get the job that you need to get that's going to help support your family. If you don't have the job that's going to help you support your family, then you can't have a home that is safe and secure. That discrimination puts you under an enormous amount of stress. Perceiving that stress, when you feel all hot and mad inside, something is happening. It is changing your cardiovascular system, your autonomic system, your inflammatory system in ways that predispose you to having cardiovascular disease and diabetes and other chronic diseases. It also is changing your genetics. So all of our chromosomes have these little protein caps at the end called telomeres, and they help protect us against chronic diseases. When we age, these telomeres get shorter, and that's why as we get older, we're more likely to get chronic strange diseases and die. Racism exposure shortens your telomeres.
If you are constantly being bombarded by stimuli, what ends up happening is that your aging goes out of control.
We talk a lot on this show about racial health disparities, and one of the most glaring and heartbreaking examples is maternal mortality. The U.S. already has the highest rate of any developed nation, people dying from complications of pregnancy and childbirth. But it is worse for people, especially Black Americans, whose maternal mortality rate is 3 times higher than that of white Americans.
People say issues around moms and babies are some of the easiest things to fund because it's moms and babies. But guess what? It's not just moms and babies, it's Black moms and babies. There's a whole nother calculus to how we understand and think about Black moms and babies.
I got pregnant during a pandemic, during the racial uprisings prompted by George Floyd's murder. Throughout that process, I think what was important for me at that time as a new mother, as a young Black woman, it was, what does it mean to give birth at a time like this? People were literally putting their life and lungs on the line during a pandemic, protesting to find out if, how do we honor Black Lives Mattering? I took my pregnancy test a month after George Floyd's murder. It was a very remarkable experience. It was joy, it was excitement, but it was also fear of what it meant to carry Black life and to birth Black children and to raise them in sustainable communities amidst state violence, anti-Black racism in its local and global iterations. At the end of the second trimester, entering the third, I was diagnosed with gestational diabetes. I did not know what that was. At the time, I was just my partner and I, we just practiced dieting and found ways to kind of stay active and keep exercising. I distinctly remember having a conversation with a white woman nutritionist person. I thought I was eating properly, I was exercising, I didn't have any history of anything intense. The way she was communicating the diagnosis to me, she was explaining it and basically letting me know that, I wasn't doing what I needed to do. She's worked with women like me before and, we just need to follow her plan. There were so many assumptions in that conversation and it made me wonder, how are they teaching people to interact with people before the clinical encounter, before that moment of birth? How are they, sort of sharing information about the multiple, because pregnancy itself is a risk factor for so many things, right? And so how are you sort of providing that broader context in a way that's culturally sensitive and respectful and not just affirms my humanity and dignity, but recognizes it as a crucial aspect of the way you provide care?
Black women are not treated the same when they go to have a baby and have visits and seek care. The underlying issue is the race. We are treating Black women differently. And to admit that, it's a hard pill to swallow. Those assumptions, those biases that we bring to the table are causing the harm.
Definitely felt stressed because here I was collecting all the information, trying to make sure I had all my ducks in a row. I had a birth plan. I was really intentional about creating the best conditions. So I had a scheduled induction at week 39. I gave birth at Wednesday at 7:34 p.m. And so it was 2.5 days of the induction process, which was incredibly long. So my husband is in the room. We're waiting for the induction process to develop. He starts feeling sick and they suggest that he leave the premises. Here I am giving birth to my first child. And at the time, the COVID policy and restrictions had a continuous policy, which meant that once you entered the premises, you can't leave. So therefore, the proposal that my partner leave because he was throwing up, he felt sick, was scary for me because that meant that I could give birth and he might not return. How we handled it was just try to communicate that he's not showing other symptoms of COVID, and that's when it was suggested for him to leave the premises to go find testing. I communicated that it's important for me to have birth support, especially given the statistics nationally and in Massachusetts of the sort of outcomes and rates of what happens to Black women and women of color when they go to give birth. I emphasize that birth support is instrumental in improving our health outcomes. And I try to explain this so that I can say, please have my partner stay here and have him get tested on site.
You're doing this kind of explanation while you're in labor.
While I'm in labor, as in legs propped up, laying on that, delivery space. And he got tested. He did not have COVID. And I remember one of the nurses coming up to me and she said, in so many words, I'm sorry that I didn't speak louder for you.
Maternal child health has always been viewed as a societal indicator as to the health and well-being of nations. Pregnancy is a medical condition. It's a normal physiological process. If you are having poor maternal morbidity and mortality statistics, then there's something either wrong with your health system, there is something wrong with your nation, or both.
That is not the opinion of leading medical experts in this country, from the CDC to HRSA to HHS to other countries around the world.
People felt like COVID was causing the disparities, but minority populations have higher rates of essentially all of the conditions that are going to make outcomes worse in COVID patients. Higher rates of cardiovascular disease, higher rates of pulmonary disease, higher rates of autoimmune disease, liver disease, hypertension, like you just go across the board. And so if someone's starting place is with those conditions, and then there are also people who are more likely to be frontline workers who are driving the bus, who are driving the train, who are working at the supermarket, that's going to put them at increased risk to get infections.
On the agency's website, its director, Dr. Rochelle Walensky, with a powerful commentary saying the pandemic highlights generations of the negative impacts of racism on public health.
CDC Director Dr. Rochelle Walensky wrote the agency is studying how race impacts an individual's health, stating, quote, over generations, these structural inequities have resulted in stark racial and ethnic health disparities that are severe, far-reaching, and unacceptable. CDC saying that they are encouraging public discussion of racism in public health.
That idea of integrating this work into literally everything that we do and having it be part of the conversation, I think those types of declarations help that, which I think is really important, but those are just words.
You can't just make declarations. Racism is a public, okay, that's nice, but what are you going to do? We can't leave it up to the elected officials. People have to organize and galvanize and push and put pressure on these folks.
It's only important if you actually do something about it. To make bold, grand statements with no follow-up action. That's worse than not making that statement at all.
So you go on, your labor progresses, you have an epidural.
A white male resident student came and gave me the epidural. That process was a bit terrifying because something was being inserted in my spine without being explained to me. I had a wonderful nurse who was there at the scene. The nurse said to the resident, she wants an explanation of the process before you begin. This person kind of just said, stay still, and I need to give you the epidural, stay still, or else it won't happen. And at that moment, I was just stunned. How I felt was so devalued and violated. I felt hurt. I felt hurt because as I looked at this white man, blue eyes, blonde hair, about to inject this thing in my black, brown body, all I could think about is what does it mean for me to put my life in his hand? Luckily, that nurse that was present, she stepped up, she used her privilege, and she used her professional title to intervene where she saw this is not working.
You're an assistant professor, well-read, in the birthing process. And I'm thinking, here you are having to explain what you know is not right about what is happening to you. It seems like the education, middle class, did not protect you.
No, it didn't protect me to have a PhD and to have a professor title while giving birth as a Black woman. I know it's a different experience if I went in there as a working class Black single mother birthing by myself. That's a different experience. I'm not gonna sort of devalue the degrees of privilege that shapes the experience that one has in those institutional contexts.
Mm-hmm.
The head of the anesthesiology department came to me and asked me what happened and apologized for how things unfolded. Apology is not enough, right? Because what we need is structural and systemic change. White guilt only takes us so far. That's not going to save Black women's lives.
I don't want a private apology. If it happened publicly, address it publicly, apologize to me in front of the entire staff and everybody who misstepped. Because you doing it privately is between me and you. They're going to go and do it again tomorrow. And what are you going to do? Go apologize in private again tomorrow?
The sheer fact that Black mothers with a college degree have a higher maternal mortality rate than white women with a high school degree tells you
That the healthcare system and that our society is not set up to protect Black maternal health.
I was teaching a course at Harvard University. It was a course on Black motherhood. Black women, they were pissed off at me. They were mad. They thought, here I am at Harvard, and you're telling me that I can have the best education, but the statistics say that my risk of having a preterm delivery, low birth weight, or even maternal mortality is so much more than that white woman who is my counterpart, and even someone who is not my counterpart. How can that be?
Oftentimes, these college-educated women may be the quote-unquote wealthiest people in their families and may be supporting other generations through their very stressful, high-demand jobs, trying to navigate the workplace as opposed to being able to have more of a restful, nurtured pregnancy because they have to maintain their position in the workforce. You may see more premature births as a result of that, and consequently more problems with maternal complications as well as infant complications.
More educated Black women, you have something added. And what that added is you're in an environment that may be predominantly white. You're the first woman, you're the first person of color in that environment. There's a level of stress that you're feeling that maybe the lower income woman would not feel.
The question is, what are we doing every day to make sure that we aren't dying and that we aren't leaving hospitals without our babies?
I was pregnant right around the time of the uprisings because of George Floyd's murder. I knew I was having a boy. So bringing another Black man into this world around the kind of political atmosphere at that time, I mean still, right, was extremely worrying. We also moved into a new house. And one of the things that we had to consider very seriously was school district. Is he going to be the only Black child? It's never ending at how the world will see him. The pregnancy was pretty standard, exciting. I didn't know what to expect. Then, when it came time to deliver, they said that my son was likely 10 pounds, but because I'm a little bit petite, they'd rather be on the safe side and induce me when his due date comes. I didn't know any better. I was like, all right, if that's the process, no problem, let's do that. We checked in, they began the induction process. And it was so uncomfortable. And my husband was like, well, I guess we just have to roll with it. So they administered the Pitocin. We waited a couple of hours. And then I started feeling contractions. It was extremely painful. And then they started happening every 15 minutes, which I didn't think was normal. I don't know what normal is, but I was like, this is a little too extreme. They also said you shouldn't be feeling this much pain. So they gave me morphine, and after like 2 hours, I wasn't responding to the morphine. I was in incredible pain. And they said it would probably be time for an early epidural. It took probably another like 10 hours before I got that. And so they said, well, the baby's not in distress. So let's wait. Let's wait for you to dilate a little bit more. We waited for hours, turned into days. I checked in on the 23rd, and I labored from that moment, from 7 hours after the Pitocin, right up until the 25th, 2 days later. Then there was a shift changeover between doctors and nurses. The doctor that finally did come in, though, after that shift changeover, he was shocked. He was like, how long has this happened? Within 30 minutes of him coming into my room, he ordered surgery for a C-section. At some point, they told my husband to get out of the room because something was happening. And so they handed the baby to the pediatric nurses and they asked him to leave. It looked like I was going to need a blood transfusion because I lost so much blood. There was so much pressure on, I don't know if it's my cervix or the uterus. I'm not sure where the pressure was, but it caused a lot of bleeds and they couldn't locate where all of the blood, the source of where all the blood was coming from. Eventually, they did get it all with sutures, and that was that. I try always to not jump to the race card. That's not where my mind instantly goes. But I have a friend who had a similar experience, similar experience. Like she was induced, failed to progress, and she got a C-section in 14 hours. She's a white girl. I don't know why it took 40 hours for them to finally say, all right, and a shift changeover at that. How was my doctor comfortable to say, she's not progressing, but you know what, it'll be the next person's problem?
In 1937, it was estimated that the number of trained Negro physicians would need to triple for Negro patients to come under the care of Negro doctors. Little has changed in almost 100 years, and the numbers of Black doctors continue to be appallingly low. This lack of Black doctors is about much more than representation. It is a matter of life or death. Several published research studies now show that Black patients are less likely to die when they are cared for by a Black physician versus a white physician. However, because only 5% of all doctors in the U.S. are Black, there just aren't enough Black physicians to provide Black Americans with life-saving care. One cause of the shortage of Black doctors is the closing of 5 of the only 7 medical schools that existed in 1910 for training Negro physicians. The 1910 Flexner Report, published by the Carnegie Foundation for the Advancement of Teaching, states that of the 7 medical schools for Negroes in the United States, 5 are at this moment in no position to make any contribution of value. They are wasting small sums of money annually and sending out undisciplined men. This was a 180-page report that devoted only 2 pages to discussing the medical education of the Negro, and those 2 pages irreparably harmed the future development of Black medical schools. It was unrealistic to believe that white medical schools, which actively excluded Black students, would suddenly take an interest in admitting and training them. And for several decades after the Flexner Report was published, there was a decline in the number of new Black doctors. Many white medical schools resisted until the mid-1970s, before they were pressured into accepting their first Black medical students. The Association of American Medical Colleges estimates that only 46,000 currently active physicians are Black. Research published in the Journal of the American Medical Association estimates that over 27,000 more Black physicians would have been trained over the past 100 years if those 5 Black medical schools that closed after the Flexner Report was published had received the philanthropic and government support needed to remain open. What Abram Flexner got right was his assertion that the Negro will be cared for better by good Negro physicians than by white ones. One study published in 2020 in the Proceedings of the National Academy of Sciences shows that when Black newborns are cared for by Black physicians, they are much more likely to survive. When white newborns are cared for by white physicians, they experience 290 fatalities per 100,000 births. The same was found for white newborns cared for by Black physicians. However, when Black newborns are cared for by white physicians, they experience 720 fatalities per 100,000 births. But when Black newborns are cared for by Black physicians, they experience 463 fatalities per 100,000 births.
Some good news tonight that could help close the racial gap in healthcare disparities. BNC's Jamise Price reports there's a boost in Black student enrollment at medical schools across the country.
More Black students are enrolling in medical school, making this year's class more diverse than any before it. This year, more than 2,100 Black students started their med school journey. 3 years ago, that number was just over 1,500. It has been a combination of factors, from the pandemic to social justice issues that were brought to the forefront in 2020.
The language that the people that we serve use is really different than the language that we have been trained to listen for. The algorithms that we try to pull together when we're looking at our diagnosis and treatment. Sometimes I can look in a Black woman's face and she just will look me straight in the face and say, baby, something just ain't right. And I know that that is her professional way of telling me shit's really wrong, right? The other mechanistic thing that's happening is you're not in conflict with your healthcare team. You're not begging them to believe you or to even listen to you. When you have concordance, you also get a vulnerability and insights into their home environment, whatever they've tried to self-manage at home, how they've been living and for how long they've been living with what we would consider to be signs and symptoms that there's a problem going on.
Going into when I'm in clinic, seeing patients, seeing that they get a little bit of a smile on their face when they see me walk in the room, because that's not what they're anticipating. I was talking to a colleague the other day in dermatology. The dermatologist walked in the room with the medical student who was Black, and the resident who was Black, and the faculty member who was Black. And apparently the patient was like overjoyed and like laughing and giggling and smiling and everything. And we can't do that enough for patients because we don't have enough of us.
Serena Williams had to save her own life. Ignoring symptoms or assuming that the algorithms don't apply because they're thinking about epidemiologic likelihood of something when there's a patient sitting in front of you who is telling you what a symptom profile looks like.
And they're telling us one thing and we're not listening to that. That mentality, that thought process going is killing our community of Black women. A lot of patients come to me seeking me specifically and my team out. And their reasoning is, and I quote, I don't want to die. We're not going to go somewhere we don't trust someone. It's a spiral down if they don't trust us.
I just remembered when I was getting the epidural, I disliked how the nurses treated us. And I don't know what happened when they were leaving the room, but I kind of like slumped down in the bed and I tried to call to her like, something's wrong here. And I just kind of fell in the bed and she was at the door talking to the epidural team going, gosh, you guys are busy. Hey, it's the second time I see you on my floor in like, I don't know how many minutes. And they're having a whole conversation. My husband had to leave the room for the epidural. He's not allowed to be in there. And so he's trying to get back in and she's like, oh, wait, let me make sure. And then she turns around and I'm in the bed and she's like, oh my goodness, get back in here. And then they got back in. I don't know what they did. They fixed it within minutes and I was okay. But I was like, oh my gosh, what just happened? And they're like, oh, no, you're fine. It's okay. Nothing.
No explanation.
No explanation. And I scoured the medical notes to see what that was. What happened? It's not in there either. I wanted to see every single detail of everything that happened because I didn't get the information that I needed from them. And I needed to understand what happened. What was the bleeding that they said they thought I was going to need a blood transfusion for? Was everything okay with the baby? Because nobody told me that either. I'm just hoping that everything is okay. They're telling us how much the baby should be nursing. He is exhausted. He was tired. He was in position for 40 hours and my whole body was squeezing down on him. He had to endure that whole process too. And so he's not feeding how he's supposed to be feeding. No, I want him exclusively breastfed. How do we make it happen? He's lying there tired. I am exhausted. And the only thing that is like paramount in my mind is get this baby eating. Forget how tired you are. Forget how hungry you are. Because I hadn't in the 40 hours that I was laboring, I was allowed like a little ice chip or something to suck on. That's it. So I am starving. I'm shaking. I'm so hungry. I haven't eaten in 2 days. But the only thing I can think of is how do we make your body make more milk? And how do we get this guy to wake up so he can consume that milk? Because weight gain is the big worry now. So I really didn't have time to process the trauma of it immediately in that postpartum recovery room. It's only in those first weeks when I went home that I started reflecting on the whole experience and I got so angry. The nurse comes in the postpartum recovery. Oh, he needs a shot of vitamin K, lifts the baby, jabs it in his thigh. I'm like, that's not a football. That's my son. It was anger with tears, lots of sadness, that this was my experience.
Healthcare only attributes about 10% to the overall causes of premature death within the United States. Behavioral issues contributing about 40%, social circumstances about 15%, environment 5%, and also genetics about 30%. Now, one might say if you think about behavioral factors, and oftentimes as physicians we think about things like smoking and diet, maybe substance use disorder, lack of exercise, obesity. Sometimes people think of those things as, well, if one would just take personal responsibility and try to do a better job in terms of modifying those behavioral factors. But actually, those behavioral factors interact with social circumstances. They interact with environmental issues as well. And so it's not just a question of thinking about what the individual does, but where they live.
I would love for somebody to go into wealthy neighborhoods and catalog every exact thing that's necessary that has been associated with or can guarantee or predict good health outcomes. If we were serious about really wanting to improve health outcomes, we would catalog what the basic minimum, components to ensure good health outcomes are. And our policies would ensure that everybody would have access to those things.
Client in DC who was on Medicaid, the system failed her baby. She had a baby at 24 weeks. So the baby was viable, but the hospital system, because she was on Medicaid, there are only 2 hospitals that she was allowed to actually birth this baby. And one of those hospitals was not the state-of-the-art NICU. They would not allow her or would not transport her baby to the state-of-the-art NICU hospital because of her insurance status. Baby died maybe a week later. That is a system failure, the fact that she was a Black woman on Medicaid in DC.
Hospitals were segregated like everything else. Hospitals like Grady Hospital in Georgia, they had white sides of the hospital and Black sides of the hospital. There still are Black and white hospitals. We don't name them that way. But if you were to walk through the wards or the floors, you would see a predominance in some of these hospitals if they're not closed, because in our communities, there have been hospitals that have closed.
When there's racial segregation, normally the white population is benefiting from that segregation and the Black population is not. The majority of Black women who are giving birth in Black serving hospitals. We also know that the resources in those particular hospitals are not as large as the resources are in white serving hospitals. So if you have a situation, a hospital, that's what we call a Black serving hospital, you're going to have higher rates of uncompensated care. You're going to have higher rates of individuals who don't have insurance.
The social determinants of health do not drop out of the sky. They are a result of policy decisions. We all came together and decided that the children's health insurance program was important. We can make policy decisions to make sure babies get fed. So the social determinants of health are not some mythological thing that falls out the sky and, we need to do something about that. Those are a result of policy decisions.
Before you're pregnant, you need to talk to your doctor. Do you have underlying conditions that's going to predispose you to having preeclampsia?
So when we think about the presence of something called preeclampsia, women who have inadequate prenatal care, sometimes the condition is not recognized.
And then when you're in preeclampsia, where your blood pressure is high, you're retaining fluid, that's a dangerous period of time. And if that's happening in real time, you can't get on the phone and call your primary care doctor and say, this is happening. And if you don't have insurance, it's a difficult situation. There's a high mortality rate with that.
In this country, insurance is tied to having a job for the most part. Lots of other developed countries don't do that. But here, in order to be healthy with insurance, you have to have a job or be extremely poor or disabled or very old.
Americans romanticize emancipation as the thrill of freedom. But as Union soldiers reported, it was actually thousands and thousands of freed people crowded together, sickly, disheartened, dying on the streets. No physicians, no medicines, no hospitals. Emancipation released enslaved people without making any provisions for access to food, shelter, employment, or medical care. Without access to employment, freed persons were forced to contract their labor back to former slave owners. A small number were able to use those labor contracts to obtain medical care for themselves and their families. The wages were meager, the benefits were small, and they often had to pay for all or part of their medical care. Agreement made this 28th day of December, 1865, by and between B.F. Fortner and the undersigned freedmen, for the purpose of cultivating the plantation. The said freedmen shall furnish their own clothing and pay for all medical services rendered to them. And in case that the said B.F. Fortner shall furnish anything more than is mentioned in this contract, that it shall be retained out of their wages when it becomes due. The contract simply provided them with a white intermediary who could compel a white doctor to treat a Negro. Freed people who attempted to work independently were often without access to a trained physician because almost all doctors refused to treat Negroes, even when they could pay. On the rare occasions that former slave owners entered into labor contracts that provided full medical care, they did so in an attempt to reassert power over newly freed persons by including clauses that referenced slave ownership. Entered into this 25th day of August, 1865, between J.F. Stevens and Freedman Elix Stevens and his wife, Margaret Stevens, to be well clothed and shod, and to receive food and medical attendance during the year. And the said Elix Stevens and wife agrees to bind himself and wife to render true and faithful service as they have done while living here as slaves. Within 1 year after emancipation, freed people began abandoning the system of contracting with former slave owners because they quickly learned that they were being tricked into marking an X or pressing their thumbprint on labor contracts that provided only 2 meals a day for their labor. The federal government recognized the need to provide some form of health care for freed persons. So 2 years after emancipation, the medical division of the Freedmen's Bureau was established to treat the many sick, feeble, and suffering freedmen who were in destitute circumstances and unable to employ a physician. This bureau was the nation's first attempt at federally funded healthcare and lasted only 3 years before being shut down due to President Andrew Johnson's fear that providing healthcare for freed people would incite dependency. The Johnson administration responded to reports that the majority of the freed people who are overtaken by disease are unable to pay for medical attention by stating that the charity of the government must be guarded. Federal guidelines stipulated that if freed people were deemed capable of being able to find employment with their former slave owners, the Bureau was to deny medical assistance if they became sick. Historians point out that although the primary mission of the Bureau was to facilitate the creation of an able-bodied labor force, limiting access to health care actually created dependency because freed people were ravaged by sickness and disease. This reluctance to care for the health of formerly enslaved people lives on in America's lack of a universal health care system.
Not only whether you have insurance or not, but the kind of insurance that you have, public or private, influences the quality of care. The difference in care between women who have private insurance and pregnant people with public insurance is huge. You see that one person every time.
Why don't they have insurance? They may not be employed. Why aren't they employed? They've been excluded from those pathways to getting a job. And that goes back to education, housing, employment, and healthcare.
Every time we have an advance in healthcare, there's the opportunity to widen the gap, because who's going to have access to that new technology, the new medicine, the new whatever? It's going to be those who have access to resources. And those who don't have the social capital, the financial resources, the good health insurance, they're not going to. And so that just creates the opportunity to widen that gap. And so every time we have something new come along, things can actually get worse unless we have equity in mind.
I had an individual that I was supporting through a loss. She was birthing her baby at 21 weeks. She went into the hospital from a doctor's appointment. The doctor told her, oh, just go into the hospital for observation. The doctor failed her right then. Her water had broken. There was no reason for her to go to the hospital just for observation. She was going to the hospital to have this baby. So that was the first part that should have happened. Her OBGYN should have told her then that you're going to have to birth this baby and you're already starting to have contractions. There's no way that this baby's going to stay in you for another 3 weeks till you get to 24 weeks, which is vitality, in order for you to birth this baby and not have an infection over 4 weeks. That was the first failure. So me coming into the birthing space, it's different to birth a baby that you know that's not gonna make it. It's a different experience as a doula. So coming into that space, I knew that. I knew what I was coming into. There was a lot of commotion in the room, so I kind of kicked everybody out and was just like, hey, I need to just focus on her and her partner. Let's work on them to get them in the right space before I bring everybody else back in. I asked her what they had shared with her about what was happening to her body. She said that she didn't. They just said that she needed to be there for observation. And I was just like, well, that's not what's happening. Let me get the doctor. So I went back out, found the nurse and the doctor, and I said, hey, can't tell her that she's going to be here for 3 more weeks on bed rest till this baby comes. You need to tell her exactly what's about to happen. They broke it down to her. Obviously, lots of tears, lots of cries, lots of wailing, because she thought that she was going to be in there for another 3 weeks. Told them also to give her options on what she can do to progress her labor. And she decided that she wanted to go ahead and move forward with getting medication to progress her labor.
Typical that you'll think about the loss to that mother. She lost her baby. If she didn't lose her baby is sicker. Her baby needs time to recover. She needs time to recover.
The placenta would not come out, and the doctor attempted to pull the placenta out. That caused a lot of other problems. She ended up staying in the hospital for an additional 3 weeks because of the failure of that doctor trying to remove the placenta versus allowing her body to contract and release it on its own. And it only had been probably 30 minutes, so they could have waited another 30 minutes to an hour to let this placenta come out on its own. She wasn't able to even do a proper burial for this baby, do any type of, she was able to hold the baby and care for the baby, but she just missed that opportunity because the system failed us. She ended up having more issues than what she came in there for, and more trauma.
Not all pregnancies end in birth. And so we also want bereavement leave for people, to cut off your pregnancy care because you had a miscarriage. There are just inhumane things that we do. People who have miscarriages on stillbirth should be able to continue to have their pregnancy-related coverage.
I experienced 2 losses. I lost a baby boy at 39 weeks. He was full term. And then I had a loss at 18 weeks with a little girl due to cervical insufficiency. With my experiences of loss, they provided me all, the resources, funeral homes, places that I could have got my son and daughter cremated. They gave me all these options. They did this just because it was protocol. And it really wasn't until I started interviewing people for the podcast to realize that not everyone got that same first-class treatment that I received. Most people are just sent home and really sent home empty-handed.
After over 20 years of dealing with infertility, I miraculously conceived. And my husband and I, we were so excited. We were like, wow, after all that time, it's finally going to happen. And I remember bleeding. I called a nurse practitioner and I told her, I'm bleeding. What should I do? And she goes, well, some bleeding is normal. Continue to relax. Don't stress out. And we're going to keep your 11-week appointment. And nobody called you in? No one called me in. I'm thinking I'm 41 years old. I'm pregnant. From my chart, you may consider me high risk, but I would think I would call me in to the hospital.
Just at least check, of course.
Yeah, to just see, if things really are okay. So I remember her saying, just don't get stressed out, just relax. And I continued to bleed, and the bleeding increased. And one day I just went to the emergency room and I was like, I can't take this anymore. It was almost like no one was checking for me at all. I was on a gurney in the hallway of the emergency room. That's how filled it was. I just felt insignificant. I went and had my ultrasound. The ultrasound tech said, oh, we see the gestational sac. And I'm thinking oh, that's good news. And she's smiling and I'm smiling too. And I'm like, okay, that's good news. I'm feeling a little more calm and reassured. And I call my husband, things are okay. Maybe, this bleeding is not a big deal. Shortly after, that doctor came over to the bed and she goes, I'm sorry to tell you this, but you are in an active miscarriage. You're actively having a miscarriage right now. And I'm like, what do you mean? I just learned that, the gestational sac is visible. That sounds like good news to me. And now you're telling me that I'm having a miscarriage. Within minutes' time, I had to call my husband back again, who was waiting outside. in the car because of COVID. I had to tell him that, no, in fact, we are losing this baby. It's pretty devastating. It still is. Some days I'm fine performing at my job. People are essentially unaware of what I'm going through or what I've gone through. But then some days out of nowhere, I fall apart. I'm still healing.
Majority of pregnancy-related deaths are preventable. And what does that mean? It means it's unnecessary death.
At our doctor's recommendation, we went into Cedars-Sinai Hospital on April 12th of 2016 for what we expected to be a routine scheduled C-section. Langston is born perfectly healthy. Everything that we had talked about, everything that we had dreamed about, everything that we had hoped for is finally here. I can see the Foley catheter coming from Kira's bedside begin to turn pink with blood. They come in, they assess Kira, they call for several tests, including a CT scan that was supposed to be performed stat. So that was around 4 o'clock. So 5 o'clock comes, the blood work comes back, it's showing that all her blood levels are abnormal. She's sensitive to the touch, she's beginning to lose color. So there's very clear signs early on that Kira is hemorrhaging significantly internally, but still no CT scan. 6 o'clock comes, still no CT scan. 7 o'clock. Now by 7 o'clock, Kira is shivering uncontrollably. She's in more and more pain. And so I'm talking to the doctors, I'm talking to the nurses. They took Kira back to surgery. And he opened her up. There were 3.5 liters of blood in her abdomen, where she had been allowed to bleed internally for almost 10 hours. And her heart stopped immediately. There's no reason that Kira should not be here with her sense today. Even though there's a lot of smiles, there's a lot of joy in our home, there's nothing that can fill that gap.
It was not that she was sick. It's not that she had a pre-existing condition, that she had a heart problem or she had a blood clot. None of that was Kira's case.
Black and brown women all over this country, they're not being heard and they're not being seen, being believed, being heard, being taken seriously. When I say I'm in pain, I'm in pain. And it's not pill seeking. I know women, especially with endometriosis, which is super painful. It's so excruciating that they would be in bed for days. Wow. And they presented themselves at the hospital, and the folks that they encountered did not believe them.
The healthcare system, they were more concerned with why I was pregnant instead of actually supporting me. Even the birth experience, it was very traumatic for me. I didn't have kids for almost another 15 years after that.
It was a lot.
It was a lot. It just didn't seem humane to me. The way they were treating me, it was a disaster.
Half my team were teen moms, and they talked about this notion that there was something really wrong with them because they were teen moms. You still got places kicking people out of school when they have pregnancy.
So my first pregnancy, I was 16 when I gave birth. So I was really young, didn't know much at all. My mom was my biggest support with everything. So I kind of like waited before I had any more. So he got a good 8 years of life on his own.
Community, how do you think were they supportive?
Some will look at me like, what is she doing pregnant? But I didn't let it stop me at all. I continued school, work. Thank God for my mom, because if I didn't have her, I wouldn't have been able to do none of it. For me too, as far as school, they had like transferred me out of it.
They transferred you out of the school?
Transferred me out of my school. It's like a bad example for the students that they have.
Wow.
Yeah.
That's sad.
Now that I'm older, I always think back like, how many other students did they do that to? And because I didn't say anything, how many more are probably still going to it?
It's like they try to put a lot of shame.
Yeah,
the shame. Well, you carry it, because I carried it for a very long time. I had mine at 14. But as you said, my mom was my support. Like you shouldn't be made to feel ashamed. Like you did, like you're a bad guy for just becoming a mother.
I'm not too sure if it was the doctors or my mother being the voice for me. She could have been the reason why they were on top of things that I needed back then. But she was very determined. So I feel like because she was there, that's why my experience wasn't as bad as it could have been.
Oh, okay. That's good.
Yeah.
I want to move away from that narrative that the womb in the uterus of the Black brown woman is dangerous, poison, toxic, and at the end of your pregnancy, there's going to be a terrible outcome. Let's move on to reimagining what is possible for Black and brown birthing people. One of those safe choices that comes to mind, of course, is a doula for every woman that wants one. Insurance mechanism that doulas will be able to be paid for, because they really are the ones that will advocate for you at your birth.
How many people have access, though, to doulas and midwifery services? And
mostly all of the hospitals around here, they offer free doulas. And they do. And I did not know that until I became one. I'm like, wait, all this time I could have had a doula. Like I could have had someone support me and listen to me and be there for me. And I asked everybody in my family, like, have you ever heard of a doula? And they're like, no, what's that? I'm like, good question, but apparently you can get one for free. After that, I started to see that there was like a divide and different resources out there, even though we're literally in the same hospital.
I just learned through my experience about doulas. I'd never heard of them before, and I didn't know anyone who had a doula.
A doula is a birthing companion that supports clients through birth, postpartum, and in some cases bereavement. What I traditionally do is empower my clients to advocate for themselves. When I have a client, a part of my intake process is to ask them, what do they envision their birth being like? Think of how you want the room to smell. What music do you want to be playing in the room at the time? What do you want your postpartum experience to be like? And for a lot of Black women, we don't ask. We don't ask for the help that we need. And sometimes it's just as simple as just asking and saying specifically exactly what you need at the time for people to show up and support you.
When I think of parenthood, I think of exuberance and exhaustion. I love mothering Rose, and I also acknowledge that mothering is hard. It's labor. And it often requires you to reconsider, reevaluate the things that you need, the things that you desire and love, and what's sort of most immediate, what's most practical, and what's most feasible for your child and your family.
What would you want other Black women to experience during the pregnancies?
One where they don't have to question if they're being treated with respect. One where they're, affirmed and dignified. One where they feel like there's shared decision-making throughout the entire process. One where they're presented with all the options and not having any of them withheld because of any their social position or identity.
Peace of mind and an experience that just leaves them feeling valued. When you Google, what should I plan for? Plan the nursery, pick out the colors without worrying, am I going to be a statistic at the end of this delivery? What's going to happen when I get into the hospital? Will my partner be allowed in the room? Should he need to advocate for me? My husband is 6'3", big and Black. So will he be seen as a threat? Should he have to say, look, she's in pain and this is what we need. Is he going to be escorted off the premises because some doctor didn't like how they were spoken to?
No amount of racism, violence, no amount of inequality, no amount of miseducation, no amount of dehumanization, no amount of lies and fake news will undermine that. Don't we deserve joy?
They definitely deserve joy. It's just difficult to try and protect a child's joy while also telling them that their joy has parameters.
When you're feeling hopeless, when you're feeling angry, when you're feeling like I'm not getting the care that I need, that impacts not just on your emotions, it impacts on your spiritual part of who you are. So you're trying to hold on to hope. You're trying to hold on to the possibilities. And sometimes it becomes very, very difficult. And it becomes a spiritual struggle. We're spiritual people. And that's kind of what has allowed us to be able to handle the disappointments, the discrimination, the hopelessness, but at the same time say, you know what, I'm going to get the hell up and I'm going to do this shit again, no matter what. We've been getting up and we're trying, and we're getting up and we're trying. But at the same time, the healthcare system has to meet us somewhere.
When I have conversations with white people about this, some listen and some, well, you know, I'm sorry this happened to you, or it's I didn't have anything to do with it. My people didn't own slaves. So that, you know, that's not where we are right now. You're right here and now. What are you gonna do about it? Don't apologize to me. Do something. Act.
Power is knowing. My colleague explained it to me, and she said that everybody has power in any situation, and I was pissed off. Like, what the hell are you talking about? This Black woman who has got all these constraints and all these challenges, and you're telling me she's got power? And she said, think about Nazi concentration camps. Think about a woman who's crying, and she's cold, and she's scared.
How you doing, sis? You okay?
Another woman comes over to her.
What's up? Can I sit with you?
Yes, sir.
Why you sitting here today? Because of George Floyd? I understand that. We're having a mental health crisis, so please do not do anything. I want to talk to her. You're not going to tell me that I can't sit with my people.
Hugs her, puts a blanket around her, and just comforts her.
Do you need anything? Can I hug you? You're video recording instead of protecting her. Protect Black women.
So I really appreciate your time. Thank you
being here and watching the documentary, and also staying for this conversation after. If you don't know, so I am Michelle Keels, the producer and director and writer of the documentary, and it takes a lot of time. I am amazed. So I give so much credit now to artists and what they can do in terms of helping us communicate our science after going through this process. And one of the first things that I say whenever I'm talking to an audience like this is for us to maybe, don't necessarily have to sink 2 years of your life into doing a documentary, but maybe think about what we can do in terms of partnering with the arts and artists, in terms of having the science, and then thinking, how can we communicate this in a language that I have no training in, but is a language that will connect my message more with those that we want to take it and run with it, do something with it. So thank you. Thank you for being here. And I will have my co-panelists introduce themselves really quickly first before we start with any of the questions.
Hi, I'm April Whedon. I work at Community of Hope. Community of Hope is a large nonprofit here in DC. Our organization has two primary focuses, one on ending homelessness for families in DC, and the other focus is on access to healthcare. So we operate 3 federally qualified health centers in DC. One of those health centers houses the only freestanding birth center in DC as well. So I am the director of perinatal services. So I am one of the directors on our maternal and child health team. Our team has about 30 positions on it, to include positions for WIC, home visiting, doulas, perinatal care coordinators, and navigators. And we also use group care models. So my team also staffs our group facilitators for those care models as well. So happy to be here with you.
Good evening, everyone. I am Stacy Cunningham Penny. I'm an executive project director at the National Institute for Children's Health Quality. I oversee and manage the national network of perinatal quality collaboratives. Perinatal product PQCs, if you've heard of them, are state-based collaboratives working to make measurable improvements in infant and maternal health outcomes using quality improvement efforts. I've been at the organization for 4 years. NICHQ, the acronym, really focuses on improving and making bold advancements and improvements in children's health. Of course, can't improve children's health without improving birthing people and moms' health. So we also are the coordinating center and national technical assistance center for the federal Healthy Start projects as well. So really excited to be here tonight.
Thanks to both of you. And so the first question that I'm asking both of you is for us. We're going to start broad and ask, what do disparities in Black maternal and infant health reveal about the broad societal systems that drive racial and socioeconomic health disparities?
So, I think Dr. Monica McLemore said it best and really pointed out that a nation's its health is determined by the infant mortality rate, and I argue also the maternal mortality rate. So if we are looking at that and we're seeing that our healthcare system is failing Black women, Black birthing people, Black infants, then we're looking at the impact that it has on economics. So if we're not addressing disparities and health disparities and inequities, then we're looking at higher healthcare costs. We're also looking at a system that is not addressing it's not addressing how antiquated it is. That's what I was looking for. And so it's not making improvements. So if we're not making systemic and systematic improvements, how can we expect to help if we're not help everyone else? And I think back to my first job at the National Black Child Development Institute, and the CEO and founder, Evelyn Moore, would say, we need to help. When we help the least of them, we help the most of them. So if we can't even help the least of them, and looking within the healthcare system and making improvements, how can we help the most of them so everyone is impacted by this crisis?
Yeah, I was speaking earlier with you, and I think one of the things that always resonates with me is that the system is not broken. The system is functioning exactly as it was designed to do. It is continuing to function exactly as we are asking it to. And at the bookend of that are women of color. But we also have to recognize in this system that there is also gender and there is also class, right? And so while Black women and other women of color are definitely at the bookends and are suffering the greatest cost of this system, we are also seeing poor white women who are suffering at this system. When we were watching the documentary, white babies are dying too. White women are dying in labor as well and are not getting access to what they need. And the issue that I continue to see is, when will they see themselves in what is happening, right? And so as we think about the feminist movement and all the work of Black women in the feminist movement only to be pushed out, and we see so much now of doulas have existed in the Black community for centuries. This isn't new for us, right? And so as research pulls forth some of this data and we start to think about it, I just want us to be careful as well about how we conceptualize these as innovations as well, robbing communities of color of their ancestral practices. They are not innovations. They've had them for centuries.
And then the next question that we have is going to be specific to this population, but is something for all of us to think about in our different population papers, which is around creating trauma with psychological trauma within our group as we were talking about health disparities.
Yeah, sounds better.
And so the question is, how do we discuss Black maternal and infant mortality and morbidity without creating additional psychological trauma for Black people? And I asked this question because after one of the screenings that was to a Black-only audience, didn't have to be, but it was a social justice film festival. A lot of the young women in that audience came up and said, well, does this mean that I shouldn't get pregnant? And it was like, no, it doesn't mean that you shouldn't get pregnant, but you need to go into that process armed with information. Kind of the ending of knowing is power. So what do you need to know so that you have power? So how do you guys have those insider conversations about these issues without creating fear?
So you said you mentioned it a little bit, and I think it's about honoring the stories and using them as fuel for action, and that's how I try to approach it. But in honoring the stories, it's also about moving beyond the stories. So a lot of course, working with PQCs, a lot of times we'll hear that one of their hospital partners is interested in having a patient come tell their story at a grand rounds or what have you. And I think at some point we have to look at, when do we stop telling those stories to the physicians? Because to me, if you haven't read or seen the headline, or if you haven't seen the New York Times article, or ProPublica, or Health Affairs, or right, then there's a problem, and that you're part of that problem. So I think it's also about looking at how we move beyond and what do we do now. And we talked a little bit about this. I use this perspective when I'm tackling. It's really like a systematic reflection, but I use it when tackling social issues like maternal mortality and morbidity, and that's the what, so what, now what, right? We know that we know the what. The physicians know the what, and so by being cautious of re-traumatizing someone, maybe having that story told, let's really focus more on the so what. So what does this mean? What do the statistics mean? What does it mean for, what implications does it have for the lives of Black women and Black birthing people? And then the now what? Now what are we going to do about it? So I think it's also about creating spaces still for us to be vulnerable and authentic with each other, while being cautious to not be traumatized, and looking at other ways that we can honor those stories and hearing from women, but learning from them already.
I kind of go both ways with this question. I think that we have a lot to be angry about. And I think that, especially as Black women, we are never allowed to be angry. And so there is that space as well. And so, rather, one of the things that I get to experience a lot being in direct service is that many of the staff that I work with, this is their very first job out of their MPH program. They come so excited and ready to do those programs that they read about in their textbooks and have the conversations that they were having and talk about stages of change and do health education. And they are always so struck by the absolute deep, deep pain and trauma that many people are carrying with them. And one of the things that I often try to remind our staff when we're having these conversations is to, one, continue to hold positive regard, unconditional positive regard for the communities that we're speaking about, right? Which for our staff are us. We have the privilege to hire staff who are from the community, who look like the community. And so they're not just looking and thinking to themselves, oh, this is really sad, this is happening to her. This is really sad, this is happening to me, to my sister. I sit here on this stage, my PhD educated first cousin had a stillbirth. I have had multiple experiences in my friendships and family relationships of unsafe sleep deaths as well. And so I sit here also saying, I have these experiences too. And one of the spaces that I try to hold on to is that in a lot of this work, we are also focused on the deficit. And we fail to also call forth how much our communities are doing to not just survive, but to try to help each other survive. And there is a lot that we are doing and gaining. Black women are one of the largest growing populations of college educated people. They're going on in higher numbers to go on for advanced degrees. We're seeing more Black children raised in two-family households. There are more dads present than we are talking about and addressing. The communities are coming together. They're offering each other free doula services. They're going back and getting their lactation certifications to help each other because they know that we're not going to be right. And so I just also put forth that yes, these issues exist. We deserve and should every one of us be angry and mobilized through that anger. And I also just don't want us to forget as we talk about us as people, that we are people who are also living a journey and are having joys in that space too. And wins that we need to be celebrating and talking about just as much as we want to talk about teen pregnancy rates, right? And gun violence in communities as well.
So the next question is around part of how the documentary ended, which is trying to offer one of the things that is listed as a solution, which is around midwives and doulas and births moving out of the hospital setting or being doctor-centered, and particularly because of the role that midwives and doulas can play in advocacy and in helping to think about more what the patient wants and less this is what I was trained to do. So you're going to be going through this process that I was trained to take you through, and all of those things. And then one of the striking things around that is as we've moved towards midwives and doulas, there was this awakening that, and if we think about concordant care, it's probably even worse than physicians in terms of the percent of doulas that are Black. And it's also an interesting history because the majority of midwives were Black before birthing was moved into a medical, into a hospital setting, and now we're having to recover that. And so my question is around, as this is being put forth as a way forward, what are the challenges faced by now having to recreate our system of Black midwives and doulas that was lost? And so what are those challenges, and what are some ways to support that healthcare workforce?
Community of Hope, for the last 5 years, we've had a Healthy Start grant that we receive as a sub-grantee through DC Health. It has allowed us to have 2 doulas on staff. Those are salaried doulas. They have full benefits. They are full-time employees, and they have flexible work hours. When they need to go to a birth, they go. If someone calls them on Saturday and says, I'm worried about my baby, I can't get my baby to latch, they go. But there have been many challenges in this space. So one, in DC, Medicaid will reimburse for doula services. That was passed a couple of years ago. And as I sit here, there are only a handful of doulas in DC who are credentialed through Medicaid to receive reimbursement. The last number I heard was 2, and one of them works on my team. And so that's not working. And we need to ask ourselves, why isn't it working? What is limiting our doulas from getting to be a part of the system? DC did not receive the Healthy Start grants this year, so I will not be able to be a sub-grantee. And internally, we're having conversations about how are we going to sustain this program that offers doula services. And so now we're looking at these reimbursement rates and we're trying to figure out how are we going to keep this doula team. But it's not just the doulas that I've got to pay for with their reimbursement. They have to have a manager. We have overhead. They've got a billing team that has to bill for them. The policies that you heard about in the film around how many people can be in your birth room still exists 4 years later. My doulas go to the hospital and cannot leave. They can't switch out with each other. They can't leave. And they're considered one of the family's visitors. So they lose a person to be a part of their birthing experience. Sometimes that means that the families do choose. I'd rather have my mom, my partner's mom, and my sister, because I'm not about to argue with them. You've got to go because I've only got 3 visitors. So we have several issues there. There's also the space that I'm watching happen as well, is that many of the doula training programs, as I've said, doulas have always been a part of the Black community, and many of these programs are white-led. They've decided what it means to be a doula and what it means to be certified. And Medicaid also said, these 20 organizations are the ones that you can be trained through, and those are the ones that we believe will certify you, and those are the ones that you must go to if you want to be paid. And so, we are seeing this, and we're also seeing that many of them are having really negative experiences going through these doula training programs, and they're talking about it and trying to create other training programs for themselves. But as we also go through this process of reimbursement, I also know that it's going to push more and more doulas of color, indigenous doulas out of these spaces, because we are also institutionalizing it, right? Much like we saw with midwives, right? When we took birth out of the hospitals, we also decided what it meant, like who could, what you had to do, what was the rigor towards being a midwife, right? And so we put all of these certifications on it. We do the same thing with lactation support. Black women have the lowest breastfeeding rates. And it is also in conjunction with the fact that we have decided who can be a lactation educator, who can be a lactation consultant. You have to sit through hours and hours of instruction and also provide thousands of hours worth of practice and sit for an exam, right? So we keep putting barrier after barrier in front of the people who know and can and want to support people.
Interesting. So I think what I can add is where I think a significant challenge is the lack of integration into the healthcare system, and that's doulas being integrated into the healthcare profession. 98 we know 98% of births happen in the hospital, and you touched on something. We can only have a certain number of people in the room, right? So that's the challenge. There's a challenge, but also how we can support them by truly increasing awareness among healthcare professionals. 98% of births happen in the hospital. So increasing the awareness and education of those working in hospitals to truly understand what it means for a doula to support a birthing person. And this really came to light. Something I did mention is I did finishing my DRPH program at University of Illinois Chicago. I actually will be defending on Monday. Thank you. And what came out, I interviewed nursing and QI teams, quality improvement team leads at Illinois hospitals. And I have a series of questions. My dissertation is focused on structural and organizational factors that influence Black maternal morbidity. So that everything that we're talking about, right? And as we were talking, I did actually have a specific question. Do you have the adequate number of staff? Most people, everyone said no, we don't. And I said, so how are you addressing the gap of the overburdened and overwhelmed staffing? And I said, do you have doulas or midwives on staff? And asked this question of everyone. And one person, a nurse, said, well, no, we don't do that. I just feel that doulas need to they just need to support. They need to just hold the hand of the patient. I really love this program that she's very flippant about it. I really love this program that we have in Illinois for girls. And the whole role of the doula is to hold the patient's hand and tell them, it's going to be okay. They don't need to be telling a patient. They come in, they tell a patient, you don't need the Pitocin. You don't need this. So you can tell there is a sense of anger. There is a sense of, I don't want to say entitlement, but like entitlement out there, how dare they come in and do that? As someone who had a doula, a Black doula, as a woman, there was nothing better than having her in that room with me. And so I heard that and I was thinking, wow, how many others feel this way? I'm sure many others I know many others feel this way. So what can we do? So that's the challenge. And so to support them, we need to truly educate and increase awareness about the role of doulas and how they support. There's evidence-based, there's research that demonstrates that Black women do better when they have the support of doulas. So through the National Network of Perinatal Quality Collaborators, we are doing research with the intern from GW, actually here, to look at how many PQCs and their hospital partners are integrating doulas in their work. And there are quite a few. And we hope to publish. So that's another way to engage doulas in research too. So another way to support them. So I hope in a year or so, we'll be able to tell you how well we're supporting, how PQCs are elevating the role of doulas in healthcare.
And so the last question that I want to ask, we'll start up here, but asking you guys to think about it also, because I want those responses, which is, in the doc, we showed that the CDC declared that racism is a public health threat. So the question is, what needs to happen for that declaration to have a meaningful impact on narrowing racial health disparities? So how do we go beyond declaration to have it as one of the experts said actually mean something.
That is. How do we go beyond?
How do we, that racism is a public health threat? We have declared that. The CDC has declared that racism is an issue. How do we go beyond it simply being words?
I talk a lot about adaptive solutions versus technical solutions. So when I think about what I call maternal mortality and morbidity, a wicked public health problem, because it's wicked, meaning it has so many tentacles. So when I think about that, my example is there's nothing wrong with technical solutions, but we are at a point where we need to go beyond technical solutions. So a technical solution might be equipping providers or training them on implicit bias training. It's not enough. And in the research I did, and even talking to a lot of white nurses, they said we need something more advanced than implicit bias training. We've got it. So we need to start to figure out what are the underlying systematic solutions that we can utilize to address the racism and microaggressions and biases and discrimination that's happening in the hospital. And that's what I really feel. So again, looking at the now what, like you said, we've got the words, we know it's racism, we hear, now what are we going to do? And that takes a level of adaptive thinking, systems thinking, to truly make system level change.
Thinking a bit about that. I think one of the spaces that I often think about around, especially what Stacey just said around the trainings, right, is how many of our HRs are ever allowed to say anything happened because it was racially viewed or race was operating, right? It was unprofessional, right? It wasn't appropriate, right? And so I often think about how we aren't setting forth policies to go forth with the training. So what auditing of their patients is happening and how are they being held accountable to that? How is their pay being affected? How, every year, many organizations should go through an evaluation. And so I think about those things often, but I think that one of the things I've really been sitting with around what is happening right now in our country is how important community is and how important it is for us to truly be within community with each other. And I know I'm taking a sidetrack off your question, but because I do kind of look at this space, and the question is kind of like swallowing the sea. So I think about myself in this space, and I think about how many of us are birthing away from our familiar homes. Many of us are transplants. We don't live where we were born. We don't live near our parents, our sisters, cousins. You don't have any siblings. Many of us consider ourselves lucky if one of our parents can take off for a week after the baby was born, come. And I was sharing earlier with someone how often at our organization, about 85% of our patient population are Medicaid recipients, and that number is higher for our perinatal population because we do operate that birth center and because we use midwifery care. And we're fortunate enough that almost our entirety of our midwifery staff are Black. So they seek out Community of Hope. But in this space, I just think about, what it means to be this alone while you are trying to create a life and parent that life. And so many of us have no level of support. Our patients at our office often ask for a C-section. And when you ask them what's going on, it's about, I don't have anyone else to watch my kids, and someone is going to be available that week or my mom already has a flight to come that week. I need to have my baby that week. And my baby cannot come at the end of her visit. I need my baby to come while my mom's here. And so I just think so much about community and what are we doing right now to really invest in people knowing each other, supporting each other, coming together as collectives, because that is who we are as humans. We need that as well. And I think that that is one of the ways that we can begin to heal ourselves while we come to more solutions around this problem.
Can I add one other? And it actually was something Congresswoman Adams brought up, and I can't remember if it was in the film too. I could be mixing it up. But another way to just not have wars is to continue to invest financially, but also our time into HBCUs and medical schools and the pipeline of Black and BIPOC and health medical students and health professionals, not just medical students. But so if we truly want to change and make systems change, then we have to change how they are being trained. And April and I were having this conversation also. It's not just white physicians who have shared biases and discrimination. So we need to, yes, there's evidence that shows that Black babies obviously are more likely to live if they're treated by a Black physician. But just something to keep in mind, we have to untrain a lot of our professionals who are trained now. So let's look at how we're training and our current medical students, our high school students, STEM programs, to change how we're going to make them, to really be able to make that shift.
Are there, I really meant that. So I'm, as you think, as I walk down with this microphone, to make sure. What are your thoughts on what needs to happen for the declaration that racism is a public health threat to actually matter in narrowing racial health disparities?
I think that the CDC wasn't clear. They didn't describe the type of racism that they meant. So it's easy for public people to think that you're talking about meanness or someone not liking someone, and so therefore taking advantage of someone. I think the CDC could have been more clear about the type of racism we're speaking of. I think that type of clarity would say that this public health crisis is actually an opportunity if they were clear about the type of racism that they meant, if they were clear that it seems to be structural, if it was clear that it's likely to be systemic, then you can find solutions to those things. The systems were created by people. Therefore, it's easier to find solutions to that. But if you think it's about somebody not liking someone or someone not appreciating someone's life, then you get stuck with this, I don't know what to do about it. So that's what I think. Does that help? Okay.
Yeah, I don't think CDC was clear on what they meant by it when they said it. I think there was a lot of public health departments throughout the nation that were declaring racism as a public health emergency, and it was to make the declaration, but not really have a clear understanding of what that meant. But I think underlying that though was when public health declares a public health emergency, typically what happens is resources become available to then investigate, to understand, to delve into and create solutions. And so to me, that's what it actually was. There was a hope that because there were all these declarations that more resources would follow. And unfortunately, I'm not sure that I've seen that happen. I think at the time during COVID, there was a lot of resource that was pushed into addressing the inequities that we saw playing out. But unfortunately, whether it's the child tax credit going away or whether it's pandemic funding going away or food nutrition programs going away, those things just have not been sustained. And those are the kinds of things that really make a difference from a structural perspective. And so I think that there was a hope that these declarations would lead to more resources, but I haven't seen that.
And I think that you touched on something, and one way, like you said, it opened the door for resources, but it opened the door to have conversations. And so I say all the time, one of the positive things that came out of the pandemic was that we can be unapologetic about the conversations we're having around all forms of racism, with structural racism, overt racism, what have you. But I think one way that and I'm not trying to get political, just happens to be this administration. The Biden-Harris administration has shown that resource is the historic investment in Congresswoman Adams talked about the historic investment they've made in maternal health, and many of those are focused on shifting systems and addressing the high Black maternal mortality rates. And so, from $36 million that they're putting towards community-based organizations to another $105 million they're putting towards Healthy Start. So I think that's, we're seeing that, but we need more, right? And we need to keep doing more.
Other thoughts on this?
Hey everyone. I'm gonna keep it very brief. But I am someone who grew up here in DC and I volunteered at the birthing center. It used to be located very close to me, and I always tell this, like, it has moved across the highway. So in order for even the people that I used to volunteer with and serve, they have to cross New York Avenue to get there. And a lot of those people had small children. We used to do mother and daughter or children yoga. We used to do prenatal care. And the idea that you have to get on a bus, cross the highway, get there, that stop has no shade. It's usually very exposed. It's right next to the highway. So if you're a pregnant woman standing next to the road waiting for a bus, you're inhaling fumes, you're dealing with traffic issues, and that's just adding more stress to your already stressful, potentially stressful situation of being pregnant. And when I was at the birthing center, I remember they were saying it was such a revolutionary place because we were really trying to encourage Black women or women in DC to stay out of the hospital. They don't have to go. You don't need to go to a hospital. You can do this more comfortably. You can do this in your community. And so when we talk about racism, we also have to talk about, like, city planning, really, and how that affects it. If you're putting a birthing center next to a major highway, who's going to use that? If you have a car, great. If not, like people in DC like myself, I'm on a bus. And it really exposes our already exposed population to more environmental factors, health risks, stress factors. And then the fact there's only one in DC, it's crazy. They closed one of the maternal, I think, wards in Southeast or Southwest. And I remember when I moved to DC, and that was such a big news because that was the only one. And they were saying, well, where are these people going to go? And I heard nothing else after that. And I was watching news, watching Congress, like, what are they going to do about this? They keep bringing up Black maternal health, especially here in DC, when you compare the rates from, the I think District 1 or 2 in DC versus Southeast, Southwest.
Yeah,
it's
7 and 8.
Exactly. It's almost twice the national average, I think, the last time I saw it, just here in DC. And this is a small city. So if the nation's capital can't figure it out, I think that we do have a long road ahead of us when we're talking about the larger United States.
And I just want to say that that birth center that we had there on 17th and we didn't own it. We were there at the graciousness of the Developing Family Center, and they had to sell that building because they redeveloped it into a nice, beautiful parking lot and high-rise apartments. You don't even recognize that corner when you drive by it. And at Community of Hope, every month we spend about $4,000 on Uber rides for our perinatal patients to get into our care. We pay for them to come in for their prenatal visits, for their newborn visits, for emotional wellness supports while they're pregnant as well. And if their baby is in the NICU, we will also pay for them to go see their baby every day in the NICU as well. And so I do think there is a space. I know we've been here today talking so, much on the national level, but we really do have to truly understand what this looks like in our communities. We are never going to come forth with any solution that's really going to help families thrive until we really truly understand how absolutely difficult it is to be pregnant and parenting in this nation. The option now, if you live in Southeast DC, you have to go to Northeast DC or Northwest. The only birthing locations are in Northeast, Northwest, and the Northeast one is on the verge. It's really in Northwest. I'm talking about Washington Hospital Center, right? So for many people, that is a 45-minute to an hour and 15-minute trip through buses, metro, plus walking, right? And so that's just not plausible for people to do that while they're pregnant. But that is what we expect, right? That's what we expect them to do because we built it that way. And that's why I say the system is working exactly the way we built it and continue to build it.
We didn't even talk about maternity care deserts, right? And so that's the adaptive solution, right? So April is doing an amazing, providing Uber rides, but we need also now the adaptive solution to build another birthing center or not close down hospitals where needed, but then we go to the staff shortage, right? That has only increased since COVID-19. So we talk about those adaptive solutions. That's what I mean. We have these maternity care deserts, and we're lacking for places for women to go.
That same neighborhood also only has one grocery store. Ward 8 has one grocery store that is always threatening to close, which is the Giant on Alabama.
Doulas being certified for reimbursement, and I was just wondering about traditional birth practices in Hawaii. They're now illegal. Are they illegal in other places for people to decide to birth traditionally? Is it illegal for them to?
And when you say traditional birth, are you talking home births?
Just not someone who isn't legally certified by a national body. Is it also illegal here? Okay.
Yes. And also punishable, right? When you show up to the hospital, you may receive a CFSA call as well. And recently in the news, we've also seen families who've not been able to receive their child's birth certificate. So there's a family in DC whose child has not received their birth certificate. They're almost 2 years old. The child's isn't a citizen, doesn't exist because she had her baby at home unassisted.
So I need to end on something hopeful, please. Well, I don't have it actually, but I'm looking to both of you to say, please, end us on something hopeful.
Well, one of the questions we talked about that you didn't ask was how do we reinstill joy, right? And I have young people come up to me after we talk about these, and they're like, Stacey, this terrifies me. Young Black women, this terrifies me to go and be pregnant. And what I say to them is, I recognize that you're afraid, and that is very, very valid. And I 100% understand. And so to do that, I want you to increase your awareness, get your knowledge, learn everything you can, but also get a doula. That's the second thing I tell them. For that support, for that additional knowledge, so it can be the bridge between you and the healthcare professional in the hospital. And also, I want you to find the joy in giving birth and being pregnant, and connect with a support group. Do group prenatal care like centering. Find your people, find your sisters, join Mocha Moms, join someone so that you can find the joy. Because it is supposed to be this is supposed to be a joyful, life monumental changing moment for good and for some of the crazy. But as a parent, but I want them to feel the joy. And that is really what I tell them. And I know what it's like to be a Black woman and afraid to give birth in this country. But I also was very privileged with having a great birth experience. So I know also what it's like to have the joy. And I want everyone to be able to feel that. I want my 11-year-old daughter to do that and her friends. And that's why I do this.
I think one of the things that sustains me is I'm always able to see that the programs do work. When we give funds to community-based organizations and community-focused interventions, they work. I am a child of Head Start. So my mom had TANF before it was called TANF. We had food stamps. We were on WIC. I have a master's degree. I went to a private women's college. And I walked away with almost zero debt, right? And I just want to say that, like, with that being said, like, I am the success of these programs and this investment. And I know that many of you all are the scholars who are doing all the research that shows like why WIC is important and why home visiting is important and having doulas and trying to support the infrastructure to create more lactation professionals and birth professionals. And these programs really genuinely work. And we need more money, right? And but I just want you to really know they work. We see every single day families who are thriving because we are able to not just connect with them on the basic needs, but we're able to do things with them like teach them how to massage their baby through infant massage classes and teach them how to wear their babies for bonding. And so we're really able to do a lot of beautiful things that impacts people's lives in such a beautiful way. And I was talking to Patrick earlier about, he was talking about a program that was workforce development, and they gave laptops to the women who were in the program. And I was like, I'm sure you impacted so much about that woman's children's school too, right? The little, there are so many little things that we're able to do with programs that we don't even measure the other impacts that happen because someone was in a workforce training program. They got access to a laptop, which allowed them to be present for virtual teacher conferences and get their kids tutoring and, all of those great things. We don't get to measure those things, and they really do happen you all. And I'm really here to say that there are people who are really benefiting from these programs and are able to thrive.
Thank you. Thank you very much. And thank you guys for staying.